Hi, my name is Vikas. I'm one of the junior doctors here in ITU. I'm presenting this presentation on myself and Dr. Carvera's behalf. So this is the PLUS trial, which was published in January 2022, which tries to answer a very important and essentially a very common question, which is part of the discussions on essentially every ward round. Which is that which fluid is better. So we have large selection of fluids nowadays, but classically we've had saline as a dominant fluid for resuscitation and sometimes treatment as well. But with these new fluids coming up in the last couple of decades, we were trying to see if they are better in any way. So this trial exactly addresses this question. Where it takes plasma light and it compares with saline. So this is essentially what the conclusion of the trial was, is that there wasn't any difference between plasma light and saline in terms of the endpoint which they were using in this trial, which was 90-day mortality or risk of AKI. How they got to this conclusion is that they asked this question first, which was that is plasma light as it is better than saline in any way in terms of resuscitation or therapy, and the endpoint was primary endpoint was mortality at 90 days. The way they have done it is the literature which has tried to answer these questions is these three main trials. So the most recent one was the basics, which essentially reached the conclusion that there is no mortality benefit of using fluids other than saline for therapy or resuscitation. SMART trial was the other trial which said that there might be some benefit of plasma light or using lactated ringer for reduction of mortality at day 30, but this trial suffered from one of the problems which most of the trials have, is that the power was very low to answer that question clearly. And then there was split trial as well, which said that there wasn't any difference between plasma light or these lactated ringer compared to normal saline. So essentially, there's a lot of information which leans towards that there is no difference, but this trial tries to address all or most of the problems which we had in the previous trials. So the way they've done is that they designed this trial as a randomized controlled trial, and it was a parallel trial where both studies were running at the same time, and it was double blind, which is a gold standard for any RCT. It was done in 2 countries, so it's dual-centric, done in Australia and New Zealand over 3 years, and there were 51 ITUs which were involved to collect data. So it's quite a big study, widespread. So data collection was done daily for first 7 days, and certain variables were taken: hemodynamic variables, urine output, organ support, laboratory data, volume of fluids administered. Data collection was done up to the 90 days, including the being on ventilator and being on renal filtration. Patients were then followed up to 6 months to see any other ill effects which patients may or may not have. The population they targeted was especially the patients who were in ITU. So that's one of the limitations of this trial as well, because most of the collection was just based in ITU. So the inclusion criteria which they used for this is that the patient needs to have a requirement for resuscitation, which was defined as a bolus of fluid administered over 1 hour or less to increase or maintain the intravascular volume in addition to maintenance. And then the further requirements were then established by using these criteria of high heart rate, low blood pressure, CV pressure less than 10, and a drop in your urine output. Also the patients were included who were expected to be in ITU for more than 3 days. So not the patients who were coming to ITU for post-op after their surgeries, who would normally stay in for a day or two. They were not included in this trial. all the patients who were included in this study had a CVC or an anterior line to have invasive monitoring done. And the question was plasma light versus saline only in this trial. The exclusion criteria was age based on age, so less than 18. If the patient has already received resuscitation, so if they received resuscitation in resus before coming to ITU, they were not included in the study. If they had any contradictions to the fluid, if someone has come in with specific fluid requirements, so if a patient has come in, for example, burns or any other head injury or any other thing, if they have specific fluid requirements, they were not included in this study. And patients who were terminal, they were also not included in this study, and patients who were known or suspected to be pregnant, or they've ever been enrolled in PLUS trial before. So initially they started with the sample size of 8,000, because that was deemed 8,800. That was deemed to be sufficient enough to reach the power needed to answer this question. But because of the pressures of COVID, they had to revise that. So they came up with another sample calculation, which was then close to 5,000, which they achieved, which gave reasonable power to this trial. So they randomly allocated patients in these two groups, which were almost equal, 2,500 patients on each group. And then based on the inclusion exclusion, some of the patients were taken out because of their exclusion criterion, or if there was any clinical disagreement or clinical need that the patient would be served better with other fluids. So these were all the reasons used to eliminate patients to reach the final sample size. The intervention which was proposed was very simple, as the question suggests, which was plasma light to one group, and control group was getting saline for all of their fluid needs. Things which both groups got at the same time were that once they were assigned, they were given same fluid for resuscitation and maintenance, even if they were readmitted within 90 days. So even if they had a failed discharge, and if they were admitted again, they were continued with the fluid they had in their first admission. Patients who were requiring a different fluid for a specific clinical indication were also allowed to receive that. And so there were some inherent problems with using a single fluid for a patient, is the problem of making these drug infusions. So some of the drug infusions require a separate fluid. So that was the only exception where the other fluid was allowed in these groups, because that was prioritized for patient care. Outcome, as we already discussed, the primary outcome is to see the mortality at 90 days, which was 21.8% in plasma group and 22%. So there is no significant difference and in both groups at the confidence interval they have set, and the absolute risk reduction ratio was also very minuscule, very small, which means that if we choose one fluid over the other, it wasn't significant enough. The secondary analysis also did not show any change in primary outcome when people receiving more than 500 alternate fluid, either prior to randomization or in the ICU post-randomization, were excluded. Secondary outcomes, there were also not significant differences. One of the secondary outcome was patients who would develop the need to go on renal filtration, because one of the problems which clinicians face normally in ITUs is that if they use saline for resuscitation, there's a thinking that it promotes hypochloremic metabolic acidosis, and it also promotes renal damage. So that was one of the factors, but it's certainly not proven that people who were on one group or the other had more incidence of requiring renal filtration. There was also not any difference in terms of the vasoactive drugs they need and the time they required off ventilator. So essentially, as I said in the beginning, the conclusion is that there is no difference between plasma light and saline in terms of mortality. But the way I see this trial is that plasma light is not worse than saline. So essentially, I think if clinicians think that plasma light will, because this just looks at one indicator, which is 90-day mortality, but there are other, and the secondary outcomes do not include specific cases, for example, DKA, where we see constantly hyperchromic metabolic acidosis in patients who are resuscitated extensively with saline. So this study, as I say, the conclusion, author's conclusion is that plasma light is not superior to saline, but it also means that it's not worse than that. The good about this trial is that, as I said, that they had a large sample size. It's a dual-centric study where they met the power standards. So that is the best thing about this. The also important thing is that the patients were delivered large volumes of fluid, so at least delivered 4 to 6 liters of fluid in this trial, which wasn't the case in all the other trials. Some of the patients did receive less amount of fluid. And the follow-up was extraordinarily successful. It was more than 90% where they were able to retain and get the information from patients who've had these interventions up to 6 months. So these were all very good things about this trial. The part about this trial was that the fluid documentation of the fluid was just while they were in ITU. So we know that patients might start from ITU, but they will go to the ward and then they will go home. So that was the part which was missing, which just muddles the interpretation of the results of this trial. But it still is the power of the study and the way they've done it it still yields very good information. The other thing is that a large proportion of plasma light group received alternative fluids. And that was purely based on their clinical needs, if they need alternative fluids for making infusions or any other clinical need that they have. So that was one of the things which was bad about this. But I say the conclusion still remains that the plasma light is not superior to saline. So that finished. Any questions anyone has?
Thank you for
Thank you.